Welcome, everyone. I'm delighted to host today. We unfortunately don't have Angela with us today, but she sends her regrets. And today and in November, what we thought might be really helpful is if we pull together some of the current plans and activities for each of our 4 scientific pillars. So today we'll be hearing from the leads of pillars 1 and 2. That's the biomedical area and the clinical area. People working across Canada on different priorities for long COVID web. My job is just to do a brief introduction, and then we'll hand it over to the Pillar 1 leads. So the first is the land acknowledgement. We wish to acknowledge this land on which the long COVID web operates. For thousands of years, it has been the traditional land on the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we're grateful to have the opportunity to work on this land. Just a very brief recap of the purpose of these webinars. First, to share evidence-based information, research results relevant to decision makers, researchers, clinicians, patients, and families, and the general public. These are all of our target audiences for the work of long COVID web. Secondly, to provide ongoing updates, spotlights on emerging evidence, and scientific information about the activities of our national network. And thirdly, by doing the above, we hope to contribute to reducing and managing misinformation about long COVID. We value highly engagement around the science and its interpretation as well as its application. A commitment to reasoned discourse, as stated in our Code of Conduct, comes with the responsibility for all of us to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we welcome any and all questions and comments in this spirit. And this is just the link to our long COVID Code of Conduct. We do have the cameras and mics off, but please post your questions in the chat. We'll pause for Q&A after each, in this case, each pillar. So after Pillar 1 presentations and then after Pillar 2 presentation. And we will do our best to review and address as many questions as we can. These sessions are recorded, just for your information, and your attendance assumes consent to recording. And with permission from the speakers, we can post this session online following the webinar. We welcome your thoughts about how these sessions could be most helpful. We do have a very brief feedback survey, which will be posted during the webinar. So I just want to say thank you and welcome the first speaker, which is going to be Lianna Falcone, who is joining us as one of the Pillar 1 leads, and she is based at the Montreal Clinical Research Institute. So over to you, Lianna.
Thank you so much, Susan, for this presentation. Thank you all. I'm really thrilled to be presenting and exchanging with you today. So I am going to share my screen. All right. So today I'll be talking to you about leaky gut and immune dysregulation in long COVID in order to get into insights into pathogenesis and biomarker identification. These are my disclosures. So we know that COVID-19 is a pandemic that tested our resilience. Almost 5 million Canadians got COVID. Almost 60 million died. And amongst those who survived, well, we estimate that 15 to 19% of Canadians will have suspected or confirmed long-term symptoms. And this might even be an underestimation of the prevalence of these ongoing symptoms. So we know that long COVID is a heterogeneous clinical entity, but I can say that it's also biologically heterogeneous. And right now we need a thorough clinical evaluation to get at a diagnosis. Biomarkers are lacking, and our current treatment interventions are symptom-based, which means that we need a deeper understanding of the underlying pathophysiology to identify biomarkers and new therapeutic targets. So I'm giving you today an update on one of our ongoing projects, and the objectives were, one, to evaluate the association between increased intestinal permeability, or what we call leaky gut, and immune dysregulation over time. and also to evaluate the impact of intestinal dysbiosis. So what I mean by that is a perturbation of the microbiome, or the community of microbes and bacteria that live in the gut. The impact of this dysbiosis in individuals with severe or neurological long COVID, and I'll explain what that is specifically later on. And how that impacts intestinal barrier function, immune dysregulation, and neuropsychological sequelae using a nautobiotic mouse model. And I'll explain what all of these terms mean as we go along. So to start, our study really begins with the IRCM post-COVID research clinic. So this is a clinical protocol, and patients are seen in our research clinic clinically, but they're, as I mentioned, enrolled in a clinical protocol where they undergo a thorough evaluation involving questionnaires and blood tests and physiological tests. And we also obtain samples that we biobank. This includes blood, saliva, stool, urine, and that's what allowed us to do these more mechanistic studies going forward to try to get at pathogenesis. And individuals are seen at any point in their post-COVID course within the 24 months following their infection. And depending on when they're enrolled, we can see them at 1 month, 3 months, 6 months, 12 months, and 24 months post-infection. So we know right now there's been a lot of very interesting studies that have tried to get at the pathophysiology that underlies long COVID, and I really feel like we have these really nice, interesting pieces of the puzzle that are coming together. And some of these pieces involve the following mechanisms. So we suspect that viral persistence can be sort of driving immune dysregulation and inflammation that may be underlying long COVID. We think that there's immune dysregulation in long COVID. There's been evidence of microbiome dysbiosis, so perturbation of the gut microbiome in long COVID, while in the acute infection, and that persists post-COVID. There's evidence of endothelial inflammation, and we've heard about the microclots. There's evidence of neuronal inflammation and how that could be impacting some of the neurological symptoms that we see. And there's been studies on mitochondrial dysfunction and how that can impair metabolism and contribute to symptoms of fatigue. So just to give you an idea, we did of what our cohort looks like. This is data from an interim analysis that we did. And it just gives you a sense. We looked at this point, it was 211 patients. And the average age of our population was 49 years, 62% were female. The majority were French Canadian because we're based in Montreal, Quebec. 20% were healthcare workers, and the majority had a mild acute COVID infection. So they did not require supplemental oxygen or not hospitalized in the acute infection. And when we looked at the prevalence of the most common symptoms, we saw, similar to other studies, lots of fatigue, myalgias, lots of neurological manifestations, trouble with memory, trouble with concentration, brain fog, headaches, sleep disturbances, could be hypersomnolence or insomnia. We also saw pulmonary manifestations, lots of shortness of breath, chest pain, and palpitations. So as I mentioned, previous studies have shown that there is a perturbation of the microbiota in individuals who have sustained symptoms at least 6 months after their infection. And other studies have shown that there is an increased risk of autoimmune condition, and there is evidence even of some tests that are suggesting that there are autoantibodies and some underlying autoimmune manifestations in the post-COVID course. So what we began to wonder is if there's a link between this intestinal dysbiosis or perturbation of the microbiome, autoimmunity, and organ damage in the context of long COVID. So first thing we did when we got a critical mass of patients that we evaluated is and who consented to provide stool samples is we looked at their microbiome. And what we found is that individuals that had a more severe long COVID manifestation, and by severe, I mean really like in this context, it's individuals that had a lot of neurological manifestations and impact on their day-to-day functionality. So the neurological manifestations, like I mentioned, the brain fog, memory issues, concentration issues, extreme fatigue, PEM, all of that. Those individuals tend to have decreased diversity of their microbiome compared to individuals who did not have those sorts of neurological symptoms, but did have long COVID, and compared to individuals who did not have symptoms of COVID and to our knowledge never tested positive for COVID. So normally when you have a diverse microbiota, that's associated with a more of a healthy sort of condition. So this is something that's interesting to see, that those who had more severe neurological manifestation had less microbial diversity in their stool microbiome. And this is just what I'm showing you is a left C analysis that shows some of the bacterial the bacteria that are enriched in the specific subgroups that we looked at. So the long COVID with neuro versus COVID negative versus long COVID without neuro symptoms. So the first thing we looked at, now that we knew that there was some sort of change in the microbiome, is we wondered, does this change cause a leaky gut? So that's increased permeability of the intestine. You know, it's just a thin layer of epithelial cells. So it could be compromised, right, in certain conditions. And the way we evaluate intestinal permeability is looking at blood zonulin levels. And what we see is individuals with long COVID have increased levels of zonulin, so more leaky gut. And that seemed to persist at least up to 24 months post-infection. And these levels correlated positively with markers of microbial translocation, so bits of microbes that could be going into systemic circulation. So we correlated that with LPS binding protein and beta-D-glucan. So again, all supporting that there's more intestinal permeability. We then looked at to see if there's any evidence of autoimmunity in our patients. So we looked at different autoantibodies. And what I'm showing you here is that there are definitely, in patients with long COVID, increased levels of some of these autoantibodies. And this also seemed to persist up to 24 months post-infection. We then looked at the immune cell compartment. We focused on the B cell compartment specifically because that's tightly related to autoimmunity. And some of the highlights I'd like to point out is I'd like to draw your attention towards these marginal zone B cells and these precursor marginal zone B cells. So what we saw was especially an increase in frequencies of these precursor marginal zone B cells, which are very much of interest to us because they seem to be these cells that are more associated with having sort of immune polyreactivity and autoimmunity. So they seem to be sort of driving us towards that more of an autoimmune kind of picture. So then, when we have more of this polyreactive or autoimmune phenotype, what tends to happen is we tend to make more, our B cells will make more IgM or IgGs, and we'll see less IgA production, especially at the level of these precursor marginal zone cells. So what I want to highlight here is that we see a direct correlation between having more IgM circulating with increased frequencies of these precursor marginal zone B cells. We also see similarly a positive correlation between more leaky gut, so more zonulin and these IgM levels. But we see an inverse correlation with IgA, so less IgA with increasing precursor marginal zone B cell frequencies. So time's flying, but the next part that I want to show is how we then wanted to show causality by recapitulating these findings in our human samples in our a mouse model. So the mouse model that we use is what we call a nautobiotic mouse model. What that means is we take mice that are germ-free, so they don't have a microbiota, they're sterile mice. And then we colonize them with a human microbiota. So here we had groups of mice that got microbiota from patients with severe neurological manifestations of long COVID. And then we had mice that got colonized with stool from individuals who had long COVID, but very mild form, very few manifestations, if any. And then we let that microbiome engraft in the mouse, and then we did a series of tests. So first thing we did is we looked at leaky gut in these mice. And this here similar to the humans, the patient samples, we measured LBP levels in the blood of the mice. And we saw that the mice who were colonized with a severe microbiome had higher levels in their blood of LBP. So that supports more microbial translocation or leaky gut. And then we looked at their tight junctions in their intestinal epithelial cells. So these are slides of the intestine. And when you have, nice formed tight junctions, so you don't have leaky gut, you see these nice round donuts. And you can see that here in a closer view. But in mice who were colonized with a severe or neurological long COVID microbiota, we start to see gaps in these donuts. So that's evidence of intestinal permeability. And then we did a lot of tests to look at their immune dysregulation. I'm pointing out one of them here because it's kind of neat and ties in with the human data. But we took a lymph node, or what we call a Payer's patch, from the gut, and we looked at IgA production. So normally you want to be making lots of IgAs at the level of your gut mucosa. That helps keep things in check between pathogens in the gut and having good microbiota and having a nice intact intestinal barrier. So as expected, in the mice who had a mild long COVID microbiota, they make nice IgA. But then in those who were colonized with a severe long COVID microbiota, we don't see as much IgA in the lymph node, or in the Payer's patch, I should say. Then finally, we looked at, we did neurobehavioral tests. Here I'm showing you data from an open field test. What we saw is the mice colonized with the severe long COVID microbiota tended to have a sort of hyperlocomotion type of phenotype. They were a little faster, covered more distance, and that's something that can be associated with anxiety in mice. And then we looked at their brain to see if there was inflammation in their brain. And surely enough, we found that the mice that were colonized with the severe long COVID microbiota had evidence of more astrocyte inflammation or activation, and evidence of more glial cell activation and inflammation compared to the mice who were colonized with the stool from patients with mild long COVID. So just to conclude this little update, what we find is that there is microbiome dysbiosis in patients with long COVID. That seems to be associated with increased leaky gut and immune dysregulation. That predisposes to autoimmunity, and together may be driving some of the neurological inflammation that we're seeing, which may explain some of the symptoms. So this is my team that I'd like to acknowledge. They're the ones who are doing all the heavy lifting. I'd like to also acknowledge, of course, our patients and patient partners and all our funders and all our collaborators. Thank you very much.
Thanks so much, Dr. Falcone. That's fantastic. A lot of work going on there. We're going to actually pause questions for you just to do the Pillar 1 questions together. And we'll turn to Gavin Oudit, who is joining us from the University of Alberta, and more work that's going on in Pillar 1. So over to you, Gavin.
Great. Thank you very much, Susan, and great initial presentation there from Lianna. So leads right into what I'm going to talk about, and that is sort of why is COVID, there's such a high burden of long COVID in patients with SARS-CoV-2 infection. And so strongly believe, and I'll show you evidence, that this is because of the high expression of ACE2 in the gut, which is particularly targeted in this condition. So this is a nice schematic here. ACE2 is actually quite ubiquitous. So not only is it in the upper and lower respiratory system, where it of course leads to infection, but it's also present.
We're not seeing your slides, Gavin.
Sorry, what's that?
We're not seeing your slides. No.
Oh, okay. Oh, I have to share them, I think, eh? Sorry.
That would be perfect. Thank you.
Yeah, okay. Sure. Go to my Zoom. Oh, sorry, got it. Okay. So here you go. Is that better?
Yeah, it's coming up now. There we are. Perfect.
Okay, we're all good. Yeah. So our work is trying to provide an explanation for why there is long COVID. There's such a burden of long COVID with this particular SARS-CoV-2 infection. and with SARS. And so our explanation fits very well with what Lianna has been showing. It's related to gut dysbiosis and that gut-enteric axis and systemic manifestation. So ACE2 is of course expressed in the respiratory system, where it leads to infection with the SARS-CoV-2 virus, but it's dominant in the gut by far, by 200-fold higher in the gut than anywhere else. And in the gut, it has some key roles. One, it controls amino acid transport from the gut lumen into the systemic circulation. It also controls peptides. And of course, it's the hijacked by the SARS-CoV-2 as a receptor. We've shown previously that this dysregulation of the ACE2 in the gut can lead to gut dysbiosis and vascular dysfunction in diabetes, in both type 1 and type 2 diabetes, something that actually can be rescued with lactobacillus overexpressing ACE2. So this is data from patients with COVID. And these are patients with acute, more severe COVID. And you can see this staining here showing this dramatic presence of heart disease, so myocardial fibrosis, but also the virus leading to loss of ACE2 in multiple organs. Okay, so not only in the heart, you can see on the left, but also in the gut. You can see the small intestine images there. And you can see the brown staining dramatically lowered in the COVID, in the kidneys. So the kidneys are, again, another organ that's affected in COVID. That's also, again, dramatic loss of ACE2, and then also less so in the liver. So it's really a multi-system manifestation and associated with loss of ACE2. I'll show you loss of ACE2 is not a good thing. And this is just a in vitro experiment we have done with HEX cells overexpressing ACE2 infected with this SARS-CoV-2 virus, showing that ACE2 is dramatically lost. So you can see in the bottom here, the red indicates the viral nucleocapsid staining, and that is led to a dramatic loss of ACE2, the green staining, and that's quantified and shown on the right. We've done a Western blot to confirm that. So you always need to show that at a protein level, not just with staining. And when we inhibit this enzyme, interesting enzyme, ADAM17, which is highly expressed also in the gut, we can suppress some of that ACE2 shedding. So it confirms that ACE2 is being lost in COVID, and it's mediated by an enzyme called ADAM17. So how does this relate to COVID? So, you need an experimental system for this because you can do wonderful biomarker work and so on, but you are limited in testing specific things if you don't have the preclinical model. So this is a mouse model, the mouse adapted virus that we created, and we tested wild type and diabetic mice because they are particularly susceptible to COVID. As you can see there on the left side, we actually had a bit of an increased mortality in mice with diabetes, a dramatic greater body loss in diabetes mice compared to wild type mice, and the clinical scoring was also worsened in diabetes. So this is a very good model. Interesting, in the left, in the diabetic mice, they cannot clear the SARS-CoV-2 from the lungs, as opposed to the wild type. So it's persistent infection, which we know is one of the triggers for long COVID when you have persistent infection. And that's shown there based on PCR analysis of the SARS-CoV-2 virus. You can see higher levels in the lungs and in the heart compared to wild type, but also that the virus is present in the small intestine, but also in the kidney. So consistent with the loss of ACE2 we have shown, we can see these widespread multi-organ presence of the virus. This is pathway analysis. So I'll make this simple. This is looking now at cardiac injury in these mice. Pathway analysis on the left shows that there's dominant metabolic changes associated with infection and reduce of a pro-fibrotic pathway. On the right, we see a very different story. You can see this is with Go analysis of those pathways, very marked differences between the wild type and diabetic mice. You can see reduced immunity pathways in the DB mice. So this is unbiased pathway analysis of bulk RNA sequencing data from the heart. And when we distill this down, we were able to detect a very pivotal pathway, Wnt signaling pathway, which is dramatically increased in the diabetic mice. You can see the heat map there on the left. It can't be any more clear cut than this, right? So the yellow versus the blue. And this leads to an impaired one of the key, most important response to treat viral infection, interferon gamma response. So dramatically altered in the DB mice, impaired compared to wild type. And it suggests, data from our group suggests that inhibiting this pathway may be therapeutic for COVID. So this is quite dramatic difference there between the diabetic and wild type animals. We went back and looked at the gut, which is what we proposed initially. And here we've shown that with this infection, even though it's a mild model of COVID, we see this dramatic loss of ACE2 in the gut. So this is quite dramatic, quite surprising actually to see this much loss of ACE2 in the gut. So this is in the small intestine, which is where the BOAT and the ACE2 predominantly work. In the second panel, there's actually when you have a genetic loss of ACE2, so you can see how much loss of ACE2 there is, about 80 to 90% loss of ACE2 in the gut from these animals. This is consistent with when we did metabolomics. You can see a clear separation there based on the PCA analysis on the left, and the metabolic changes we see systemically in the plasma correlate with what we see in patients with COVID. So we get a suppression of tryptophan, an increase in phenylacetic acid, which can mediate some of the neurocognitive changes that we see in patients, and also increased serotonin levels, which has been reported. So the mouse model with that loss of ACE2 in the gut simulates what we see in patients with COVID. Interestingly, quite interestingly, so in wild type mice at day 6, 7, even though the weights were up, but they had altered metabolomics, altered ACE2 in the gut, when we put them on for exercise testing, this was dramatically altered. So kind of normal looking mice with normal weight, when you put them in an open field test, their both total distance travel and the velocity of movement were dramatically lowered. So very much like what a long COVID patient might experience. And again, to Lianna's point, we also see this leaky gut syndrome and increased metabolites in the blood, suggestive of impaired increased permeability and gut dysbiosis. So it's good that we're seeing this in multiple different cohorts, and I think this is a common mechanism that links long COVID, gut ACE2, and long COVID symptoms. So I'll stop there. I mean, it took us a while to get these preclinical models going, but both in mice, and we've done some work in hamsters that recapsulate the human COVID condition. ACE2, I think, is a key role here, dominant in the gut, and I think it links why gut dysbiosis and long COVID exists, and why it doesn't exist in other viral infections that do not target ACE2 in the gut. And again, to Lianna's point, the important role for translational research, where we can look at biomarkers, biobank, and hopefully we can now collaborate on some of these preclinical models and some of the gut dysbiosis findings. Okay, and my wonderful team from the clinical side, but also from the preclinical side, and our level 3 facility here at the U of A, which allowed us to do this animal work, which would not be possible without them. So I'll stop there. Thank you.
Great. Thank you, Gavin, and thanks to both of you. We have a number of questions, which we have a bit of time now for. The first one relates to a topic that was brought up at the symposium, which is about taurine. And I don't know if, Gavin, you'd like to start with that one, or perhaps Lianna can jump in.
Sure. I mean, we're doing the trial, so we're just we're fortunate to be able to. So Lianna pointed to the importance of biomarkers, and she's doing great work with that. So with our biomarkers, we're able to find an association with taurine and long COVID symptoms, especially patients that can't increase their taurine levels. And this is backed by decades of really good basic science, some of which we have done several decades ago, but it's also anti-senescence, all anti-cancer, really good vascular, antioxidant, and metabolic effects of this. So we do have a funding for a CIHR sponsored trial. We're just about to finish the protocol. So there are 3 sites. Edmonton is the lead site, Toronto. This is based on Angela Chung's Reclaim platform. And then the 3rd site is Lianna's site in Montreal. So the 3 sites. So, we're eager to start the trial and to be able to provide solid evidence of whether taurine supplementation will make a difference. The taurine effects actually are linked to some of this gut dysbiosis and a lot of the metabolic changes that we're seeing. So, we're very excited to get this going, and hopefully we'll start here in a few months.
Great, thank you. A couple of questions for you, Lianna, just about leaky gut. So the first one is around what the therapeutic implications are for leaky gut. Anything can be done. And secondly, is leaky gut specific to long COVID, or is it involved in other autoimmune issues?
Yeah, excellent questions, right on the money. So to the question of the specificity of the leaky gut, so we believe that it's not specific to long COVID. I think the more we look for it, the more we're gonna find it. So one of our next objectives is, in fact, to compare our findings in other cohorts with other diseases to see if we could find some underlying leaky gut. So I saw mention in the chat of rheumatological conditions, other autoimmune conditions. I think we really have to look at that. I think that any situation where you've got dysbiosis, there's a potential to cause inflammation that could impact intestinal barrier integrity. So it needs to be looked at, definitely. The other question was about what we can do to improve the intestinal barrier. So and I see that there's mention of prebiotics and probiotics and whatnot. So I think certainly there's things that can be done to improve intestinal barrier integrity. I think, though, we still need to do a lot of work on figuring out what exactly works. I think pre and probiotics have the potential to help. But as some folks mentioned in the chat, there's a lot of unknowns and a lot of variables to consider. Okay, and that's where I have I say potential, because one, it matters if what sort of host is receiving the probiotic. So not everyone will engraft the probiotic. So there has been some literature that shows that in some individuals, they really don't engraft. There's only a small percentage of people that will actually get colonized with the prebiotic, or the probiotic, I should say, and then have some sort of sustained effect. So not, sometimes, people think if they're measuring and they're detecting the bacteria in the stool, it's because they're colonized. No, it could just be the supplement that you're finding. So engraftment is an issue. And then which bacteria you're putting, which are the ones that, with your community structure are going to really be beneficial and will help improve that barrier function. So there's a lot still to learn. But this is an area that we're very, very interested in looking at the different ways we can improve barrier function, which may or may not involve live organisms. I'll also say that there could be studies that are ongoing that are testing interventions, and they may not know that they're impacting the intestinal barrier. They may be improving it inadvertently, because it might not just be probiotics. Maybe there's other medications that will have an indirect effect on the barrier because they alter the community structure of the intestinal microbiome.
Yeah, that's great. We have done some preclinical work with ACE2, lactobacillus overexpressing ACE2, which seemed to have helped the diabetic situation, a condition where you can get a leaky gut and vascular dysfunction, but it's just preclinical, right? So to Lianna's point, to move that into clinical would take a lot of effort. And then again, to the point that we may need to pick the group of patients that respond to specific therapies. I mean, that's what we're doing with taurine also. We're using biomarkers to decide who will respond to it or not. And maybe the same thing for gut dysbiosis, figuring out what subgroup of patients will respond best to this type of therapy.
Great, thank you. I'll just take one more question. Curious about the association between antibiotics and the microbiome and severity of long COVID. If chronic use of antibiotics damages the microbiome, is there any relationship, do you think, between that individual and the severity of long COVID that they might be having?
Yeah, I mean, I think it depends on the antibiotic. So there are certain antibiotics that have a more narrow spectrum. Maybe the impact on the on the microbiome might not be so large, but there's some that have are more broader spectrum or kind of impact more critical bacteria that are important in maintaining intestinal barrier integrity, and those might have more of an impact. So it's entirely possible. So I wouldn't say all antibiotics, but I would say that a fair amount can really impact the composition of the intestinal microbiome.
Yeah, no, absolutely. One of the species that we see when we lose ACE2 in the gut is the proliferation of a species that produces antibiotics. So it wipes out your healthy flora and leads to overtakes the gut microbiome locally. So this is also something that can happen. Bacteria are known to produce antibiotics, and they can influence the local microbiota based on that. So yeah, I mean, there's a question here about kids, and of course we now know long COVID is important in kids, and so the things we're talking about here very well may be relevant for kids. I think kids have a dominant GI presentation with their long COVID. So this a lot of what we're speaking here is not just for adults, but also for children with long COVID.
Great, thank you. I think we're going to switch now to Dr. Jill Cameron, but I might ask Gavin if you wouldn't mind in the chat, just because this is a general audience, it might be helpful if there's just a quick explanation of the difference between causation and correlation in the work, that perhaps both of you could address that, both Lianna and Gavin. That would be great. Just to all, that's great. So welcome, Jill. From Pillar 2, which is the clinical pillar for long COVID web. And Jill is joining us from the University of Toronto today. So thanks, Jill, over to you.
Thank you. Thank you so much for the opportunity to give some of the membership some updates of the work being conducted in Pillar 2. I, of course, co-chair this with Grace Lamb. Unfortunately, Grace had a conflict today, so isn't able to be here. So I will be speaking on behalf of Pillar 2. So I thought I'd give you, like, essentially my presentation is going to give you an overview of what we really did during the 2003-2004 sort of calendar year, academic year. And so it's really just 3 things, and I'll get started with that considering time. So we had 14 of the long COVID web grants funded that was listed primarily as a Pillar 2 project. And then there were 7 more grants that were funded that had Pillar 2 as a percentage of their involvement. So what we did at our regular monthly meetings is we invited everybody who was funded to come and present to the group and give a brief overview of their project. And what we found is that it was really, I think, quite beneficial in that it gave opportunities for people to discuss the projects, to provide some feedback, to ask some questions, for people to develop, I think, some collaborations as a result. So I'm not going to share those 21 projects today, but there's lots of research going on in Pillar 2. I am going to highlight 2 specific projects. The first one is led by Kelly and Anne, who are both on the call today. And this was what we call our foundational project. So it was the first project that was funded in the realm of Pillar 2 and was our foundational project. So it's the Measurement and Assessment Paradigm for Long COVID, or the MAP-LC project. Oops, sorry. Oh my gosh, super sensitive mouse today. Oh, I've lost here. Okay, so here's the overall team. So there's lots of engagement across the country, across different institutions, across different organizations. There's people with lived experience on the team, caregivers, et cetera, et cetera. So it's a very interdisciplinary, comprehensive research team. When it comes down to it, this is the core group of individuals who are working together on a regular basis to achieve the objectives of this project. So I want to give them a specific shout out. So the overall aim of this foundational project was to establish a framework of measurement for adults, children, and caregivers for use in long COVID research and clinical practice. The framework that they're working to develop will include a variety of different outcome measures that are used, either patient-reported or performance-based, the purpose of the measures, the construct of interest, so essentially what it's trying to measure, the measurement properties, how well it measures what it's trying to measure, the context in which it's used, either a clinical context or for research, or also the population that it's used more specifically with, and as well as any implementation considerations. So if somebody were to use any of these measures, what do they need to think about before they go about using them? And here's an outline of the entire project, which I thought was really quite nice and kind of captures everything. So it's an evidence review, including a consultation phase, and then there's built-in knowledge translation. I'm not going to go through all of the different steps. You can see it here, and I believe this will be available later on. I do know that so far they've completed steps 1 and steps 2. With respect to the evidence synthesis, they're still going through the literature to identify articles that will be included in the knowledge synthesis. They're also still doing ongoing consultations with people who have experience using measures in the context of either research or clinical practice. And they're still looking for people to participate in that consultation phase. And I've got an email address for you in the next little bit. So they're doing really great work. Lots is going on. And it's a very comprehensive project, and it's still in progress. And oops, my goodness gracious, I apologize, sensitive mouse. Okay, so yeah, so another shout out, if you are interested in participating in the consultation phase, please email Kira McDuff at utoronto.ca. Again, this is people experience completing outcome, using or completing outcome measures for people with long COVID or their caregivers, and again, across the age spectrum, which is of interest. Oh, goodness gracious. Okay, and they're thankful, of course, is the funding for this project from the Long COVID Web, and then also working in collaboration with other groups that are working towards similar goals around the world. All right, the second project, and Grace Lamb is actually leading this. So this is an interesting project in that it's one of the mandates of Pillar 2 is for us to present a common and consistent definition of long COVID. So if you can imagine if Lianna and Gavin were using different definitions of long COVID in their research, how we may not be able to compare their findings, or their findings may not work well together as they seem to based on their presentations earlier. So the goal of this project that's being led by Grace, I don't have the full list of team members to share with you, but is really to come to consensus on a clinical definition of long COVID that can be adopted by the Long COVID Web, but also can be used in the context of research and clinical practice. So just to provide a little bit of background, the term long COVID is actually a patient-led grassroots movement that came up with this term. We also hear post-COVID condition being used quite often. It's being used by the guideline group, but I think the preferred language, of course, the Long COVID Web is named Long COVID Web for a reason. And I think that's the preferred language to use in the context of this research and this work. Of course, multiple organizations have come up with a whole variety of different definitions. This has led to some confusion as to people using different definitions in the context of different projects. So there really is a need to standardize our nomenclature to go forward with respect to clinical care as well as research. Oh my gosh, now I'm going backwards. There we go. So I'm not going to go through all of these definitions, but there are a whole host of them. The World Health Organization and StatsCan use, post-COVID condition and is defined in that way. The NIH has another definition. Yes. Oh, my mouse just doesn't want to work. I have to check my battery. The Center for Disease Control, there's another definition there, so that there really isn't any consistency. Here's another one that's a little bit more concise, and they're calling it post-acute COVID-19. And then most recently is the NASM definition that has come out. So anyway, there's lots of different definitions out there. So we need to, the goal of this project, oh my goodness, the goal of this project is to really come together with and create a definition. So separating what might be convalescent COVID-19 or maybe long COVID, separating it from acute COVID. There's a possibility of adopting the WHO or StatsCan definition of PCC as our definition of long COVID. There's some other sort of potential consequences if we do this, in that there's, it's not really about the exacerbation of pre-existing symptoms as a result of COVID-19. So anyway, there's different sort of considerations. There's some thought that clinically that those may be different conditions and maybe should not be grouped together. So the goal of this project, again, being led by Grace, the first year is really to review the landscape to see what definitions are out there and being used, the possibility of adultment, and that really is this idea of using and existing. Like maybe we decide that the World Health Organization definition really meets, is used quite consistently and really meets our needs as an organization. So there's a possibility of using that, and if not, working towards the development of a new one. And then the second year of the project, which would be a second project, would be to conduct a national survey to target key stakeholders, including people with lived experiences, caregivers, clinicians, and researchers, and work together through a Delphi consensus to create a definition that we could use in the context of the long COVID web. So currently the project is focused on adults, but there's some consideration about expanding it to kids. If you have a specific interest in that, I'm sure Grace would be happy to hear more about that and other members of the team. And that's all that I'm going to say for Pillar 2. So we can open it up now to any questions or discussion.
Thanks very much, Jill. We have a couple of questions off the bat. So the first was just about the first study, and perhaps you could put the email in the chat so people can access that. But just wondering what geographical area they're recruiting for. And that may have been answered in the chat about that it's actually an international study. Is that correct with the scoping study?
Well, the scoping, the review, so Kelly and Anne are both on the call, and they're both welcome to chime in since they're the leaders on this project. But the scoping review will include all literature from around the world. I'm sure they will be tracking where, the studies are based, countries and things like that. My understanding for the consultation is it's Canadian, but, they can correct me if that's not the case.
Okay, that's super. And we had an endorsement for the use of not using post-COVID in the language, but post-acute or long COVID. So thanks others for that. And you've put the email in the chat. That's terrific. Any other, because we have a bit of time, Jill, I'm just wondering if there's any other studies that you think look promising in terms of clinical work and therapeutics, just some of the current trials, that kind of thing.
There were so many, like when we did the presentations by I'm not sure if we covered all 21, but we covered quite a few in our monthly meetings. And if those recordings are available online, those would be beneficial. I personally can't remember all the details. I do remember one that was about the concept of stigma, and I thought that was really quite, hitting the mark. And there was really quite a interesting discussion about, I guess that also, ties into the concept of gaslighting that I know people with long COVID experience. So those are those projects. Honestly, I don't remember all the details of the different projects. And I also know now that we have, got another round of funding that's just happened, and there'll be more projects funded. So I think in general, I would say there's lots of great stuff happening. And yeah, there'll be more to share over the next little while. Okay,
super. We can, the meetings, so the pillar meetings are open. So I think in terms of interest, if people would like to join those meetings, I think we're encouraging people to write to info@longcovidweb.ca to see the process for joining those meetings, which would be great. So thank you. And a couple of questions just about symposium that we had as well. So you did have to attend the meeting to be able to see the presentations. That's one reason we had the Pillar 1 and Pillar 2, Pillar 3 and Pillar 4 in November, do a kind of a wrap up of some of the key projects in progress here. So Jill, just maybe a little bit more on sort of next steps for your pillar.
Yeah, so next steps, boy, oh boy. So Grace was the co-chair of the long COVID symposium, so we haven't had a lot of time to kind of touch base on next steps. So I think, number one, obviously coming up with our long COVID definition, and having that, something that we can recommend as a pillar. And then I think continuing to provide opportunities for people to collaborate and join research projects. I think we'll wait and see what projects are funded in this next round, and I think we'll have an opportunity to also profile those projects as they get started.
That's great. I know there's a lot of focus on the definition, but I'm wondering if you could just talk a little bit about what proportion of the problem is in terms of access to clinicians for long COVID, people living with long COVID, is the definition. Do you think if we get a definition, it's perfect, solid, ironclad, will that make a big difference, do you think?
Oh boy, that's a tough one. I think there are lots of issues. We hear about long COVID clinics being, closed around across the country. So I think that's, definitely a bit of a challenge. One thing we hear a lot from people with lived experience is just needing information to take to their doctors to help them understand. So I think that, having a better definite effect in some ways. And it might help with, and I know you've got a whole host of educational resources available on the Long COVID website. And so for people to take to their family doctors and things like that. But I think, it should help, I would hope. It will definitely facilitate research and, clarifying what people are trying to study and what they're not trying to study. So it should advance research. I think, should advance practice in many ways, I hope. Yeah.
Thanks. And we have a comment from Nandini. I think the definition is vital to diagnosis, particularly the medical codes and what is written on the health charts. Yeah, that's terrific.
Yeah, we'll have to see what the medical, I think the pillar, was it the health services pillar, pillars 3 and 4. I mean, that would be the advantage of going to one of the next round of this session, where pillars 3 and 4, because I think it's pillar 3 that's spending a lot of time with our administrative data to understand how to characterize long COVID in the context of our administrative data and what changes might need to be made so we can have a better understanding of the, the context of long COVID and care in Canada.
That's great. I wonder if I can ask Nick as well. Perhaps you could put in the chat the link to the list of resources that we developed. Perfect. Okay, thank you, Lorraine. That's terrific. So there are a number of resources there that are have been considered evidence-based and evidence-informed by our Patient Advisory Council and our clinical and scientific colleagues within a long COVID web that might be helpful to you for some of these questions. I think we could go back to a couple questions for Pillar 1, actually, if that's all right. Jill, anything else you wanted to mention?
No, I think that's quite good. We're always open to membership, and our meetings will probably get started again. We just have to get through the long COVID symposium. As Grace was obviously fully invested in that as co-chair, and then people are very welcome. And if they have ideas for what they would like us to use the regular meetings, I think, they're more than welcome to, send Grace or myself an email, or even Karen or Yalda, I think, who also helps, support us in our regular meetings. If there's anything you think we could use the meetings to do, and we're happy to do that as well.
Great. Good. Thank you. So just a couple more questions because we have a bit of time here for Pillar 1. There was a question about whether or not ACE2 could actually be replaced in the gut.
Right, and so that's what we're trying to do with the lactobacillus overexpressing ACE2. So we've done it in mouse models. I mean, there's been some really good papers on this. Maria Grant is leading this in the US, and it corrects the gut dysbiosis we see with diabetes, type 1 and now type 2 diabetes. So just overexpressing the ACE2 there does provide a lot of benefit. So I think it's something that's worth looking at. in terms of a potential therapy for long COVID. That's a bit more complex though, right? Because you're dealing with a probiotic overexpressing ACE2 and so on. So it's it's something that clearly fits with the preclinical data, and it ties into vascular dysfunction and brain and cardiopulmonary dysfunction that you see in these preclinical models that we're able to reverse by giving lactobacillus overexpressing ACE2. To move that into clinical trials, sure, but it's a big undertaking, and I mean I need to do more work on that. Right now we're putting all our effort on this on the Turing trial. So
Great, thank you. A question: given the current conversation about gut dysbiosis, some folks have actually worsened their symptoms by taking pre and pro biotics. What advice can you give to help those wanting to try these as a possible therapeutic for possible symptom relief?
I mean, Lianna, I'm sure is still there, but yeah, no, I think this is the tricky business, right? It depends on what the state of the patient microbiota is, what probiotics you're taking, and how you're going to respond to that. So when I had a patient recently, took this because he had a stroke and thought that probiotics will improve his neurological recovery, and it did the worse. He had actually 3 months of diarrhea and weight loss taking probiotics. So a lot of this stuff is unregulated too. You just don't know what you're taking, right? Like a lot of supplements. So we just have to be very careful about that. But I'm sure Lianna has a lot more to say about it.
No,
Proceed with.
I agree. Yeah, it ties into sort of my earlier comment that there's a lot of potential variables at stake. So still a lot of unknowns and more finessing that needs to be done here.
Yeah, and this is where taking the stool, assessing the stool, and then maybe deciding who will benefit from it. And the stool and the metabolomics, right, and picking the right subgroup of patients that may respond to this type of therapy.
Great, thank you. There was also a question about fecal transplantation. Is that?
Yeah, no, absolutely. Well, so we have done that at U of A here for C. difficile colitis. Very effective. Is actually clinically approved, right, for refractory C. diff colitis. So we want to do it actually in our mouse model. I know I've spoken to Lianna about that, to proof of concept, right? Correlation versus causation. So far, we've been showing correlation, really, mostly, to really prove that if you restore that gut microbiota, that you can relieve the metabolomics, and the phenotype would need a fecal transplant protocol. So we are planning to do that in mice, and again, if that's something that's positive, then it's also something that we tried in patients.
Great, thank you. I think we'll close there. I just wanted to say thank you so much. We've already lost Jill, but thank you so much for our speakers and for all of you who've attended today. The quick feedback survey is there in the chat. If you could take a minute or two to fill that in, that'll help us plan future ones. So thanks to all of our staff for helping out, and thanks so much to all of you.